If prebiotics are basically food for gut bacteria, why does the aisle make it look like I need a special powder? Are onions, oats, beans, and bananas doing the same job? Or is that too simple? I want the version that helps someone shop, not the version that turns every microbiome word into a subscription tub.
Simple is a good place to start, but the term has teeth. A prebiotic is not just any fiber. It is a substrate that hosts microorganisms selectively used in a way that confers a health benefit. Many candidates are fermentable carbohydrates, like inulin, fructooligosaccharides, galactooligosaccharides, and resistant starch. Food can absolutely deliver them, but the exact dose and mixture are fuzzier than in a study capsule, and that matters when claims get specific. And it helps to separate neighbors. Probiotics are live microorganisms given in adequate amounts. Prebiotics are the usable substrates. Synbiotics combine both. A synbiotic trial may show something interesting, but you cannot automatically credit the prebiotic part, the probiotic strain, and your breakfast oats equally. The evidence belongs to the thing tested: strain, dose, substrate, duration, and population.
So if someone wants the food version, what are they actually adding? Is this mostly garlic and chicory root bars, or can normal meals cover enough territory to matter? And if the dose is fuzzier, does that make foods weaker or just harder to study cleanly?
Normal meals can cover a lot. Think legumes for fermentable fiber and resistant starch, oats and whole grains for mixed fibers, onions, garlic, leeks, asparagus, and Jerusalem artichoke for fructans, and slightly green banana or cooked and cooled starches for resistant starch. Foods are not weaker by default. They are broader. They bring minerals, plant compounds, protein in legumes, and chewing and satiety signals. The practical goal is diversity and gradual total fiber, not finding one magical prebiotic vegetable.
Walk me through the body ladder. What happens after I swallow that bean and oat meal that makes scientists care about the microbiome instead of just calling it roughage? Where does human digestion stop and microbial digestion start?
Before the romance, fermentation makes gas. That is not failure, it is chemistry. But a sudden jump from low fiber to lots of beans, inulin bars, and chicory root can mean bloating, cramping, urgency, or diarrhea. People with IBS, active inflammatory bowel disease, recent gut surgery, or strict low FODMAP plans should personalize this with a clinician or dietitian. The goal is to train tolerance, not to win a fiber dare.
When people say prebiotics reduce inflammation or improve gut barriers, are they mostly talking about short-chain fatty acids? And how far can we push that claim in humans before we drift from mechanism into wellness poetry?
Short-chain fatty acids are a big part of the story. They can nourish colon cells, influence pH, interact with immune signaling, and travel in small amounts into circulation. But the human evidence is mixed by outcome. A kidney transplant synbiotic trial, for example, reduced LBP, HSCRP, IL-6, and SICAM-1 over 12 weeks. Useful signals, but that was a small, specific, capsule-based study in 46 transplant recipients. It is not proof that everyone gets fewer heart attacks from onions. The gut-brain claims need even more sorting. In exercise populations, a review of 6 probiotic or synbiotic RCTs with 180 people found several sleep outcomes favored supplementation, especially subjective sleep quality and sometimes latency. Interesting, especially for athletes under training stress. But that is not the same as prebiotic foods curing insomnia. Depression trials are heterogeneous enough that reviewers could not make firm conclusions because interventions, measures, and participants varied too much.
Who is the best candidate then? Someone constipated, someone eating almost no plants, an athlete chasing sleep, or a healthy person trying to optimize an already decent diet? I'm trying to separate a boring but useful grocery upgrade from a medical intervention.
The clearest practical candidate is the person whose diet is low in plant variety and total fiber. They may improve stool regularity, satiety, and overall diet quality simply by replacing refined snacks with beans, oats, fruit, vegetables, and whole grains. For disease-specific claims, it gets narrower. Adult asthma meta-analysis data suggest mild lung function signals for some probiotic or symbiotic interventions, but not enough for routine clinical use. In older adults with diabetes doing resistance training, adding a symbiotic did not beat protein plus training. Capsules and concentrated powders deserve a different threshold. They can deliver a sudden dose, sometimes with live organisms if they are symbiotics. Immunocompromised people, transplant recipients, people with central lines, severe illness, pregnancy questions, or upcoming procedures should not treat these as casual groceries. Food changes are usually lower risk, but even food should be paced if symptoms flare. A transplant study can be promising and still be something to discuss with the transplant team.
If someone tries this for a month, what should they watch besides a vague sense of gut health? What would count as a useful response versus just tolerating more fiber? And should they bother with microbiome tests, or is that mostly noise for everyday decisions?
Start with one change, not a pantry overhaul. Half a cup of beans a few times a week, oats at breakfast, or one extra vegetable serving. Give the gut time, drink enough fluid, and back down if pain, persistent diarrhea, blood, fever, weight loss, or nighttime symptoms appear. Those are not normal adaptation signals. If the goal is constipation, track stool frequency and straining. If the goal is bloating, do not ignore worsening just because the food is healthy. So my food first summary is, prebiotic foods are a sensible way to feed microbial metabolism while improving the rest of the diet. But they are not a precision drug. Expect the strongest case for stool regularity, plant intake, and plausible metabolic byproducts. Expect weaker evidence for big claims about mood, sleep, immunity, asthma, or cognition, unless the trial matches the product, dose, and person. If the first step is a calmer plate with more plants, that is evidence-aligned. If the claim is a cure, ask for the trial. Or